All right, so this afternoon we're going to be talking about two of the most difficult problems to deal with in ECD, and that's both pain and fatigue. And as many of you know, you can experience both at the same time, and this is quite a vexing problem. So we're going to talk about each separately, though I understand that you experience them at the same time, but this will make it easier to kind of pick each one apart and see where we can help you, right? So let's start with this. What we all want you to know is we understand that people with ECD can have significant pain and significant fatigue. We know that you're not making this up because there are multiple studies that have been done which show that there can be significant pain with ECD, such as from the bones, sometimes from the joints, and from other body areas. So, looking at ECD, we know that there's pain, and we also know that there is fatigue too. We've also learned over time regarding pain and fatigue in ECD by extrapolating from other conditions like cancer. So, what I want to emphasize as we talk that you can see here at the bottom of this slide is your pain is real. We know you're not making it up. That's also true of the fatigue. So we are here to try to help you. That's why we're doing the webinar today. I would like to hear from you when I'm done with the talk. So please speak up. Tell us how you feel. So we're going to start by talking a little bit about where pain comes from. And I'm going to show some pictures in a minute. But I want to start broadly by saying that pain will typically start in some area of your body, like when you cut your finger or you fall and you sprain an ankle. That signal gets sent from, say, your finger and travels to your brain, and it's your brain that interprets the pain. Now, along the way, as the signal travels up to your brain, there are other areas of your brain that will add to or take away from whatever that signal is. This is an important concept to understand because when you have chronic pain, as seen in ECD, is that these other areas of your brain can amplify the signal. That will cause you to perceive the pain possibly being greater than it is. That doesn't mean that you're making up the pain or that you're faking it because these are different areas of your brain at work. This is your brain trying to interpret the pain to make sense of it, and it's trying to protect you at the same time. So, what I want you to understand here is that pain is not only based within the body, but it's also brain based. That's hard to grasp at first, but I'm going to help you to try to make sense of that. In this next slide here, I don't know if you can see my cursor, but I'm running my cursor over these multiple areas of your brain that help to interpret the pain signal that started in your finger or your leg. These multiple other areas, and there's more than a dozen now, help to interpret that signal. They can amplify the pain or they can reduce the interpretation of pain. They add other features to the pain. And then that is sent to the very highest centers of your brain where you, meaning your mind, makes a final decision on how you experience this. So I hope that very simple explanation helped you to see that pain is brain based. And this is important for you to understand because it being brain based means there's something that you can do to help yourself. All right, so I've talked about some of this. Here, the text that's showing up on the left side. Importantly, if you look at the bottom here, what I want you to understand is through that using different means, medication, exercise, meditation, and so forth, you can modulate the signal of pain that is heading into your brain and how you interpret the signal. So, we're going to talk a little bit about chronic pain. I just want to go ahead one slide here, and I want to show you um, graphically what I was trying to say. So, if you look on, I believe this would be the left side of your screen, you might see my cursor moving around. You see that there's someone who has a pain signal coming from the bone. And then you have these waveforms here, meaning that the pain signal goes up into the spinal cord and goes up into the brain. Now, this pain signal coming from the bone pain can be only mild to moderate. So that's the actual signal. But when it gets into the brain, you have these different areas of the brain on that map that I just showed you. And those other areas can amplify the signal. And here you can see this little gauge where the gauge dial has been moved up and it's moving up toward max. And then these signals go all the way to the highest centers of your brain. And then that tells the highest centers of your brain that the pain is greater than what it started out to be. So your perception of the original signal can be amplified or de-amplified by these other centers of the brain at work. What I want you to take away from this slide then is for you to understand and for your loved ones to understand too that the pain is real. We have a true pain signal coming from the bone. And as it travels into the brain, these other areas of the brain then modify the signal. That's brain based. That is your brain at work. And then you have to make a decision then on how you're going to perceive the pain and then how you are going to respond to it. So I want you all to see that this is a complex pathway and that requires different interventions to help you reduce pain. Now, the next thing that I want to say is to talk about the difference between acute pain and chronic pain. That's important because the type of pain that we see in ECD is actually chronic pain. And chronic pain has a different physiology over time than acute pain does. So, for example, you probably all know that when you're working in your yard, or maybe when you were a kid, you fell and you hurt your knee or you hurt your hand. That's an example of acute pain. That pain will go away over hours, maybe several days. So, your brain is going to interpret that differently because the pain signal is decreasing in a short time frame. So the other areas of your brain quickly adjust to that and they help to de-amplify the signal over time because it's a short time. But when you have chronic pain, that's different. In fact, it's very different. So, for example, with ECD bone pain, now you have this persistent signal of pain coming from the bone, let's say in your leg, and it's persistently coming up into your brain. This is going on for months and months at a time. That is real pain. That is body based real pain. And because the signal is coming in over the course of months, now your brain has to begin to adapt to the pain. How does it adapt to the pain? Well, it begins to take more input from other areas of your brain. If I can, for lack of a better phrase, to make sense of it, your brain has to be able to say, why isn't this signal going away? It's been present for months now. So other areas of your brain are beginning to modify the signal. Oftentimes, when that signal gets modified in chronic pain, there's a component of suffering with it. And that is also brain based because no one wants to be in pain for months at a time. It drains you, it drains your mood, it makes you feel bad. That's then can create the suffering component of chronic pain. The suffering component or the distress, let's call it, that comes with a chronic pain signal can then amplify the pain. And that then creates the condition where you feel or you sense or perceive that the pain is even worse now. And so what I'm going to discuss is that there are ways that we can de-amplify the actual pain signal that's coming from the bone. And then there are ways that you can reduce the signal coming from those other areas of your brain. It's important for you to realize that what I've been discussing with you is brain based. And I want both the people who have ECD in the audience and the loved ones on this webinar to understand that the person with the pain is not faking this or trying to make this up. This is brain based behavior. And that's what I keep reinforcing. And you have to treat it as such. There's some other important aspects of chronic pain that I want you to see here. If we look at the image on the right, because chronic pain will typically occur day and night, and in fact, the bone pain of ECD will frequently ache more at night. It causes you to lose sleep over time. Deprivation of sleep feeds back in the brain and acts to amplify the pain. Another thing that will happen is with persistent pain and loss of sleep, then you have mood changes. And that in your brain can also amplify the pain, and it causes the pain to become more persistent over time. Another common thing that occurs when a person has chronic pain and also with acute pain, like when you fall and sprain an ankle or a knee, your brain, those safety centers in your brain tell you don't move, right? Because it hurts less if you don't move. That's a safety signal that's good for someone who has acute pain, like when you break a leg, a, a bone in your leg. But in chronic pain, that brain-based behavior of not wanting to move, that can be unhelpful over time, though the behavior itself is based on a very old program in our brains which tell us if we have pain not to move. So there's an area that we can work on too. So I have shown you three things, right? Lack of sleep, change in mood, and then becoming sedentary over time. That leading to overall a loss in energy, more fatigue. So I want you to see then here on the right how the cycle keeps going and gets worse over time. The good thing is that you can break the cycle of pain at any of these points and at all of these points. And that's what we're going to talk about. So I've shown you this image here, and you can view these slides again to reinforce that. So the first thing that I want to say about making pain better is that you have to admit that you're in pain. Now, I know that us guys sometimes we can be very tight lipped about things and we don't want to admit things. We don't want to come forth with things like this. But it is important that you tell your loved ones and your doctors when you are having pain. It is not a sign of weakness to tell people that you're in pain. That's the right thing to do because then you can get the help you need. All right. So please, when you go to your appointments, when your physician asks you how you're doing, taking your medications and so forth, don't say everything's okay when it's not. If you're having pain, please let them know. Don't try to tough out the pain because, as I just showed you, it reinforces the cycle and that's just going to make things worse. Next, to the patients here, I want to say that it's sometimes difficult for us to be able to take advice. For example, when a loved one says, gee, you look like you're in pain and you don't want to move. You spend most of the day in the chair. Let us know if you're in pain. I know from speaking to people every week about this that when we hear comments like this, especially from loved ones, we can take that as a criticism. And that's not what your loved ones want to do. They're trying to help you, but they cannot experience your pain. And if you don't express that and say, I'm in pain, I hurt, and I don't know what to do, you need to tell people that so they will understand more and then be able to get you the help that you need. So that's step one. All right. So um, I know for sure that there are times when, especially the bone pain of ECD, can be moderate level to severe. So I'm talking about on a scale of 0 to 10, where 0 is no pain and 10 is the worst possible ever. I know that that pain can be 6, 7, 8, sometimes 5 or 4, and it can get very high. Sometimes I've seen people go up to a 9 during certain times. So I want to address this head on because I get asked about this frequently. If you're having persistent pain that is of a high level, it is okay to try narcotic type medications for your pain. All right. When I say that, I mean that they should be used under supervision of a pain specialist who will assess you and see you regularly to determine what medications are best and how they should be used, how you are responding over time. So, when used in the right way, the opioids can be very effective pain medications to get your pain under control while you're trying other things. Okay? So don't shy away from using them. They just have to be used in the right way. One of the things that I do like about this class of pain meds is that they will help you sleep. Especially, that's especially important if you can't sleep at night, and they tend to calm people. So, for those two reasons, I think that this class of drugs can be used safely over the short term. All right. So, um, people will ask me, well, can you give us the names of some meds that could be helpful? So, for example, for short-acting medications, we have oxycodone, something you've probably all heard of, hydrocodone, which is sold in the United States under the brand name Vicodin. I'm showing you here low doses because I think that when I've used these two drugs for people who have, for example, let's say bone pain, these doses I've found to be effective. Okay, so 5 milligrams 2 to 3 times a day. You increase over time under the supervision of a pain specialist only if you need to and if it's safe for you. Now, there are some people who are going to need these meds over a long time period. So we're talking months, maybe more than a year. If so, you can switch from short-acting pain meds to long-acting pain meds. That can also be very effective too. And I say this because these opioids can help you get control of your pain so you can get up and moving again. So they will also help at night if you take them at night. They also have that effect of helping people to sleep at night. So you'll get better sleep, have more energy, be able to get up and move the next day. Because the goal is for you to use these other methods of controlling your pain and then being able to wean down from the opioids. So, I want to talk about some of the important side effects of these drugs. Now, this is not to say that you can't use them. I want you to go into the use of these drugs knowledgeable and with your eyes open here. So, all narcotics, short acting or long acting, have the potential for abuse. And so that's something that you have to be careful with. If you have a history of substance abuse, then you're better off staying away from these drugs. The next thing that's important to know is that they are constipating. This can occur even at a low dose. So if you're going to be taking these every day, you need to make sure that you're doing other things to maintain your bowel movements because constipation itself can be painful. And then all of these drugs increase the risk of falls. So if you're having trouble with your balance, then you need to talk to your doctor if you should really use these drugs. If you do, you need to use them at the lowest possible dose. And as always, these drugs are used safest when they're used with a specialist. All right. So I've now talked about the opioid type drugs. And now we're going to talk about some other meds. Commonly used meds that I see would be drugs like ibuprofen. I usually give this to people in a dose of about 2 to 400 milligrams. I try to stick to it about twice a day. Got to be careful with blood pressure. And if you're having troubles with kidney function, you need to keep the doses low if you're going to use ibuprofen at all. But this does have a good anti-inflammatory effect. And I also want to say that I've heard people say to me that you won't get an anti-inflammatory effect with ibuprofen unless you take 800 milligrams 2 or 3 times a day. And that is not true. That is a myth. I see people getting good pain control with 2 to 400 milligrams twice a day. Tylenol is another good medication. You can take the extra strength, which is 500 milligrams. So you can take 1 gram in the morning and 1 gram at night. Or if you have a greater amount of pain, you can take it up to 3 grams per day. But I recommend that you not go more than 3 grams in one day. If you're having a lot of trouble with your liver function and your kidney function, then this dose is going to have to be reduced. And that's why you need to discuss this with your doctors. Some people get good relief of soft tissue type pain with medications like Flexeril, which you see down here, cyclobenzaprine. This is, I'm trying to remember what the name of this is, the brand name, tizanidine, which you can use at a low dose, which is 2 milligrams every 8 hours, which would be 3 times a day. I've often had people do very well with this just at night. So there are other options here. Now for the bone pain, there are what we call anti-resorptive agents. And the most common type of medication within this class are called bisphosphonates. They can be effective for bone pain. And I've put, I think, about 3 or 4 people on these drugs. And you can, some of these drugs are taken by mouth, others are given in a vein. So either of these can be helpful. The ibuprofen, Tylenol, these I see people using every day in order to control their pain. And I know patients who are able to just use these meds. So once again, your pain specialist will be able to work out a regimen for you. I'm giving you ideas here that I want you to take to them. All right, now we're going to talk about the other important issue, which is fatigue. I just want to take a look at my clock here. And fatigue is the other vexing problem with ECD. Um, what I have seen is fatigue is part of ECD, but it's made much worse when you can't sleep at night. It can be a side effect of some of the meds you take, problems with your mood. When you become sedentary, your fatigue actually gets worse. And then, of course, there's things like a very poor diet that can also make fatigue worse. What we want you to know is we know your fatigue is real. We know that you're not trying to make it up. It's something that we have to work with, but you have to tell us how you feel. So let's talk about some of the causes of fatigue. First, there are the meds you take. They can certainly cause fatigue. Typically, what will happen is as your body gets used to the drug, that medication induced fatigue will wane over time. Next thing, and an important thing that I see, is poor sleep. That is very common because people can have bone pain and other things which cause them to lose sleep. And this really ratchets up people feeling tired during the day. Now, as we all know, that some people, when they have pain and other issues, they will become sedentary. Once again, that's your brain that's saying, let's not move because maybe I'll be in less pain. Over time, that actually makes the pain and the fatigue worse. Paradoxically, regular activity reduces pain and reduces fatigue. But at first, it's going to be hard because it seems like I'm so tired I can't get up to go for a walk, or I'm in too much pain. That's where the pain medications come in. That's where the PT comes in. All right. So people ask me about this all the time, which is, can I use stimulants? Yes, you can, carefully. All right. So um, methylphenidate, Ritalin, can be used. You probably know some people that take this medication. When I have prescribed it, I prescribe it at a very low dose, like 5 milligrams, which is a low dose. But before I prescribe it, I make sure that it's medically safe for the person to take it. And there are other choices here, which I've listed on the screen, and you can go over those and talk to your doctor about them. But I want to focus on some of the other things that I think are important for you to know. And that is that the stimulants, which can be effective, come with some significant risks. And I want you to be aware of these. All right. So, stimulants can also, there is the risk of abuse with them. The other thing is stimulants, once the dose goes up, but even at a low dose, it can increase your blood pressure and it can increase your risk of having trouble with the function of your heart, and that can increase your risk of heart attack or a stroke or a serious abnormal rhythm to your heart. Can also create an unsafe increase in your blood pressure. If you have seizures, don't take these drugs. The other thing is, I would not take a stimulant later in the afternoon or early in the evening because they may keep you up at night. And if one of the drivers of your fatigue is not being able to sleep, then you're only putting yourself into a vicious cycle if you take the stimulant later in the day. All right. And then there's always the possibility that some people, when they're on these meds, they can have strange thoughts, like they may hear voices or see things that other people don't see, or some people can get so amped up that they can't calm down and they get so amped up that they can't function. Okay, so the most important thing that I want you to know about reducing fatigue is to get your sleep cycle straightened out. That takes months or a year or more. You got to get help with that, and a sleep study is an excellent way to do that. You have to stick with the plan. And the last thing that I'll say, which is a frequent issue, is that people are sleeping on bedding that's 10 or more years old and may not be appropriate for you given the pain that you have. Uh, the most important uh, intervention that you can do is activity. You do not need to join a gym. You work with your doctor or a PT. You can walk, Just you can walk inside your home, you can walk up and down your driveway, but if you can't, you can use a stationary bike, or I don't know if you've ever seen it, which is an arm bike, which is where you have pedals and you move them with your arms. That's a good exercise. And when it's done regularly, it reduces pain and fatigue both. That's been shown now in dozens of research papers that I've read. And so I want you to use that, but I want you to know that when you first exercise, it's going to be tough. These are some other things here that I won't have time to go into because we're at 2:48 now. So I'm going to skip past them and I'm going to say that pain and fatigue is hard to deal with. Please tell people how you feel. Remember to, as much as you can, to be peaceful. Talk to your loved ones. Loved ones, I want you to know that we cannot experience what the person feels. We don't know what that pain feels like. Be patient with them. Try to help them by talking to them about how they feel. Make it a safe environment for them to open up, for the patients understand that your loved ones don't know how you feel. They can't experience your pain. You need to open up to them. So I'm asking everyone to be patient with each other. That said, I'm done. And